So good afternoon, everyone. Welcome to Research Conference. As many of you know, May is National Stroke Awareness Month, so we thought this would be a great opportunity to recognize some of the projects relevant to stroke that are ongoing here at the DCRI. We do have a full agenda today. We'll be hearing from 5 speakers, so we're going to try to move through the slides quickly and make sure we have enough room for discussion at the end. We really wanted to structure this session as a picture of the stroke life cycle, and so each speaker will be focusing on one phase within that life cycle. We'll first be hearing from Jennifer Goldsack, who's a project leader here at the DCRI, and we'll be focusing on one of our new projects relevant to primary prevention. Then we'll hear from Dr. Carmen Graffinino, who's professor of neurology and medicine, who'll be focusing on acute stroke care pathways. Dr. Ying Shan, who's assistant professor of neurology and medicine in the Division of Clinical Pharmacology, will be focusing on secondary prevention in stroke populations. I'll be giving a talk on stroke patient engagement in the PROSPER study. And Dr. Janet Becker, if we have time for her. She's Associate Professor of Medicine and Health Services Researcher in the School of Nursing and here at the DCRI, and she'll be focusing on post-stroke recovery and rehabilitation. So please join me in welcoming Jennifer Goldsack.
Thank you. So I'll get cracking. We've got a packed agenda. So I'm really excited to be here and present on behalf of the Impact AF work group, and specifically co-PIs Chris Granger from here at the DCRI and Rich Platt up at Harvard Pilgrim. So what I'll be whizzing through this lunchtime is I will tell you a little bit about my organization where I sit here at the DCRI, CTTI, or the Clinical Trials Transformation Initiative. Then I'll talk briefly about the platform we're using to run the Impact AF study, and that's FDA's Sentinel system. And then I'll spend the rest of the time until I start getting the evil eye from Emily that it's time to move on, talking about the Impact AF study itself. So City, we are actually a public-private partnership, and we were co-founded by Duke and FDA, and we sit here at the DCRI. We're actually a multi-stakeholder organization. We have over 70 members now from across the clinical trials enterprise. And we work together on collaborative projects to try and increase the quality and efficiency of clinical trials. And at least I think we have a pretty phenomenal portfolio of projects, and interestingly, the Impact AF study, the stroke prevention study, is the second project in our portfolio looking at what we can do with FDA's Sentinel system. So a nice quick segue into talking about the system itself. That system is another collaboration with FDA, but it's between FDA and some of the nation's largest health insurance and health insurers and health systems. And it was set up back in 2008, primarily to monitor the safety of FDA-regulated medical products. So to tell you a little bit about how the Sentinel system works, it's a distributed data set. And so it's full of claims data from 18 different health plans. So what kind of data does it have? It has both inpatient and outpatient claims data, but it also has laboratory test claims and pharmacy claims. So it's a really robust data set. And to give you an idea of its size, currently, now we're going to see how well I can remember my numbers, I think there's about 39 million patients currently contributing data to the data set. Since the inception in 2008, nearly 200 million unique patients have contributed data. And I think there's about 45 million patients for whom we have 3 years or upwards of continuous, claims data. So it's a really powerful resource. And as I mentioned, the Impact AF study is the second sort of project that City's done looking at this Sentinel system. And in the first, which we sort of only recently completed really, following the success of the system as a safety surveillance tool, we wanted to start to ask the question about whether we could actually use this amazing resource as a way to conduct clinical trials. And so you can see here that we found that most health plans, so of the 18, most health plans are both willing and able to work with us to use this structure to conduct clinical trials. But also when we think about what the impact of doing that could be, there's an enormous potential to reduce both the time and the costs compared to that more traditional clinical trial. So having done that initial project, we wanted to think more carefully about, well, how are we actually going to expand what we can do with this Sentinel system? How can we actually start to use it for clinical trials? And it was actually Chris Granger who suggested that maybe we consider atrial fibrillation as a fantastic test case for this. And why is AFib such a great opportunity for this? Well, first of all, it's unfortunately quite common. Patients with atrial fibrillation have a hugely increased risk of stroke. And despite the fact that that risk can be really very well mitigated by the use of oral anticoagulants, unfortunately, it's really many people who perhaps ought to be taking oral anticoagulants to reduce their risk of stroke aren't doing so. So there's a huge public health opportunity here. And to dig a little bit deeper, we did a needs assessment. So we did a quick query of just claims data from 3 contributing health plans. So that was about 16 million members we looked at, and they had data included from January 2006 to June 2014. Of those 16 million members, we found that over 200,000 not only had AFib, but we're also at increased risks because of additional risk factors. That's measured with the CHA2DS2-VASc score of being higher than 2. And of those patients at risk, we found that half had no record of any oral anticoagulation dispensing. So, that really sort of hammers home the public health issue that's out there and what incredible test case this is for the Sentinel system. So I'll tell you a little bit more about this study, and I know that it is, there are different incarnations of the IMPACT AF study, but how are we particularly looking at stroke prevention here using the Sentinel system? So IMPACT AF is an individually randomized trial to determine whether a multi-level educational intervention can increase oral anticoagulation use among patients with AFib. And so as you can see here, and as I sort of alluded to already, this is really a proof of concept study to determine whether it's possible to actually conduct a trial within this Sentinel system. And I also think it's worth sort of thinking about, again, why is IMPACT such a good study? If you think about trying to monitor and follow patients with AF who we're trying to sort of protect from stroke, it really does call on all of the different sorts of claims data that we see in the Sentinel database, both inpatient and outpatient claims, lab tests, think about INR tests, and also the dispensing data obviously is key. So, for many reasons, we're really excited about this project. So as you can see here, we've got a collaborative work group that's working really hard right now. We have a trial protocol now in hand. It's being reviewed by all of the health plans who are participating. We've developed interventional materials, and something that's sort of no small feat, but quite unique to this kind of study is, obviously all of the programming and the infrastructure that's needed in order for us to sort of identify our population and then monitor them using the database. And you can see here the different work group members that we have included. So I'll tell you a little bit more about the protocol. Our primary outcome is the proportion of AF patients who fill at least one OAC over the course of this 12-month study. We also have some key clinical endpoints that are secondary outcomes. We are looking at stroke rate. We're also looking at hospitalization for any bleeds, as well as number of days covered. What's really nice, though, again, with this sort of study is we are easily powered to look at those key clinical outcomes like stroke, like hospitalization for bleeding. So a really fantastic opportunity to get quick information about this. The intervention itself is an educational intervention going to both patients and providers. We're doing a direct mailing, and we're also building a website. And the content, I think as you all know, certainly educational interventions aren't easy. They're certainly not easy when you're depending on the US Postal Service. But we are particularly grateful for Citi's social science team and the CCGE team here, led by Dr. Amy Corneli, for helping us do a lot of formative research so that hopefully the materials that go out are as impactful as possible. Our accrual goal is 30,000 patients, and they'll be randomized up at the Sentinel coordinating system, so the different health plans won't see who from the other plans is randomized. And what's really sort of interesting, I think, about this study is this possibility of an additional external control arm. So what's that? Well, as you saw from the numbers earlier, when we queried the original data set, we found over 200,000 eligible patients just from 3 health plans. So we're going to put in any eligible patients who aren't randomized into that external control arm. And also there's some controls in the Sentinel data set about which Medicare patients we can use. So again, for those Medicare patients we can't enroll, we'll be using them in that external, that additional control arm. So really sort of exciting design to this study. So quick summary, and then I'm getting to move on. What are we really trying to do here? So to plan and execute the IMPACT AF trial, really to better understand the utility of the Sentinel system, but also because, what we're really excited about is the huge impact it could potentially have on, stroke rate in this quite vulnerable population. And also, as you would hope in sort of a true test case, is to create reusable and generalizable interactions. So not only are we hoping that this study could perhaps be replicated by other health plans if they find that it's useful and that this is impactful and effective, but also that the whole system, the whole way of going about using this distributed database to do clinical trials could be repeated in the future. And I think I'm good on time. Thanks so much. Questions at the end? Yeah.
Okay. So I'm going to catch up a little bit for you guys on where we're at in acute stroke care in very fast going slides, and then the work we're doing to try and improve access. So I stole this from Chris because I love this slide, because I really do think it's about doing more with what you got than always discovering new things. And so in one slide, a lot of people die while we wait here. This is 60 minutes. Every 4 minutes, an American has died of a stroke. So this is happening very quickly. It's the most costly disabling disease we have in the United States. And even though the mortality has gone down to 5th, the prevalence has not gone down because of the aging population. So incidence and mortality may be going down, prevalence is going up. And worldwide, it's the 2nd most common cause of death, and it's the major cause of disability, particularly in sub-Saharan Africa and Asia. So what do we do in stroke? Obviously prevent it, best thing you can do. Treat it when it happens, recover it, make sure it doesn't happen a second time. So how do you know what is happening? Well, the first thing, people have to be able to know they're having a stroke, and that's not as easy as with other diseases. So this is where the patient and family education. Then we have to get somebody to the patient, and they have to recognize that it is a stroke and figure out what's the right place to send that patient. When they get to the ED here, they have to recognize it as a stroke, because even though the paramedic may have recognized it, the emergency room doesn't always believe them, only find out later on that the paramedic was right. And then the neurovascular team has to come down, and with the assistance of the ED folks, as Bill Clinton used to say, it's about the economy, stupid, and in stroke, it's about cerebral blood flow, just like with STEMI. And so we can chemically open up the vessel, or we can mechanically open up the vessel. But, so there's good ways to do things, and there's great ways to do things. And I think this is no truer in neurology than anywhere else. And so this was a good way to do things. This was 20 years ago now, and this is using chemical thrombolysis to open up a blood vessel. But some vessels don't want to be opened up. And in the last 2 years, we've now had a barrage of studies. There's now at least 6, maybe 7 trials showing what I'm going to share with you in a few quick minutes. This is the enemy. This is the carotid artery, and that big cutoff there, that's the middle cerebral, and that is your entire right brain without any oxygen going to it. Chemical thrombolysis only opens this up about 20%, 25% of the time. So again, what's the problem with what we've done for 20 years? Crappy equipment. Pro-urokinase was the first chemical that was tested in the brain. Alteplase is much better, safer, predictable. And as I said, about 20% of the time, these big clots can be opened up. This is the corkscrew. As I usually tell patients, when you have a stroke, we pour liquid Drano down the pipes, and if that doesn't work, we put in a Roto-Rooter and try and get that clot out. This was the first Roto-Rooter. It's called a Mercy device. Well, 50% of the time they're able to get vessels opened up with it. This is the new kids in town. These are using stent retrievers. So when you hear a vascular neurologist and critical care doctors talk about stent retrievers, which is the shortcut, this is the Solitaire on top, and this is a Trevo, and there's now 2 more companies with 3rd and 4th and 5th generation retrievers. And you jam one of these into the clot, you extend it open, the clot gets snared in those stents, you collapse it down, and then you pull it out. About 80 to 90% effective in pulling out carotid, middle cerebral, and posterior circulation strokes. So this is the trial that we're going to use as the reason why we need to do what we did. Mr. Clean was a Dutch trial, very pragmatic, nicely done. What made this very effective also was the Dutch government said no one gets funded for stent thrombectomies until this trial is over. So they basically said if you're not in the trial, you don't get the treatment. And that was a beautiful way to force data to be generated rather than just keep doing it and not know whether what you're doing makes any difference. And these were patients with big strokes. NH is greater than 2, but most of them were 15 to 16. They had to come in within 6 hours. You could get TPA or you could not get TPA, where the study requested that people get it as much as possible, didn't mandate it. And what did they find? Lots of patients for stroke. This is a ginormous study. I know for cardiac, it's a pilot. But we had 196 patients in the intervention group with the artery opened. They used retrievable stents in 190 patients. Every trial prior to this, which made the pessimists very happy, like the IMS-3 trial, had used a corkscrew, which didn't work. Now you use something that works. And when you use equipment that works, what happens? This is the modified Rankin score. And just to put it into summary, a 6 is death, a 5 is wish you were dead. This is the in the nursing home, not able to do anything. A 0 is never knew you even had a stroke, no symptoms, nothing. 1, you have some symptoms, but not even a physician or a nurse can even pick up that you had those symptoms because there's no deficits. 2, you're able to live completely independent on your own, but you may not do everything you used to do. So you may not be back to the office, but you're still totally independent. 3, you need some help with your activities. You need a little bit of dressing help. You can still walk on your own. 4, you're back in the nursing home or totally dependent on somebody else. So 4s, 5, and 6s, very bad outcome. And what did we see here? Big shift in the intervention group. The first 3, 9, 21, that's total independence. We're looking at 33% of the patients in the intervention group compared to only 19% in the control group. And this is with TPA in the control group. ESCAPE was another trial. These guys use CT perfusion, CT angiography to look for small, we're getting into this concept of penumbra, small core, equally robust with or without TPA. These are the 5 trials. Extend IA, again, the top one is the one you're going to look at. Lots of dark blues and light blues, very few whites and very, very light Carolina blues. So you can see that the more the tops you have, the better the outcomes. What does this mean? Number needed to treat is 3 to cure a patient, which is unbelievably effective. Number needed to treat with Swift Prime was 4 to basically make a person totally independent. So we're looking at an extremely robust treatment. But what's the problem with this treatment? If you don't get into the hospital, you don't get the benefits. So here's the Mr. Clean trial with very much longer Emravescut on the right. The quicker you get in, the better you do. The more you reperfuse, TICI-3, which is total reperfusion, the better you do. So putting it into perspective, again, Jeff Saber calculated looking at MR that every minute that you wait to open up an artery, you lose 2 million neurons. What's 2 million neurons? People can't really figure that out. Turn it into looking at survival curves. For every minute that you wait to open up an artery, you lose a week of life. So if somebody wants to wait an hour to get home, they've just lost a year. So that makes your emergency doctors put a little fire under their backside. Every minute you're losing weeks and weeks of living. So how do we make things different? Well, we've done a lot of work in the last year to try and improve our outcomes, looking at our TPA. We're getting probably around 60+% of the patients able to get home, with the majority being totally independent. If you look at patients treated with thrombectomy, we're at 43%, which is exactly the national average. So these theoretical things are translatable into the real world. But how do the rest of the country do? Only 8% of patients in this country get TPA at best. it goes from 4 to 16%. How can you improve the system? Because we don't know, we have a treatment now, but we got to get the patients through the treatment. So how do we get data? Well, this is how we get data. Patients go to the hospital, they call EMS, first hospital calls us, we transfer them here, patient ends up going to rehab, and poor stroke coordinator has to go and extract data from every single one of these sites to see if anybody knows what they're doing, which is impractical. It's very difficult. The whole EMS system is fragmented when it comes to stroke, as it was with STEMI, and that was the work that we were basically piggyback on Accelerate and RACE to say, can we do this in neurology? So what we're working on now, and we've got some modest amount of funding and a really great group put together, is to say, we got to improve community knowledge, because if the patients don't ask for help, we can't give it to them. We got to improve access to the health, so we got to work with our first responders and how we transfer people across the system. We got to derive best practices, because in spite of all this data, same as you'll find in every other disease, a fragment of the patients get lytics, a fragment of the patients are even referred for mechanical thrombectomy, and even once you know that they've had an afibrillated stroke, they didn't even go home on an anticoagulant. So what we're looking at is first starting with education of high-risk groups, and we've got a whole program based on the American Heart Association FAST program. So we call this Think Fast and Pay It Forwards. We're asking people to learn this, teach 3 others, those 3 others teach 3 others. And then we're looking at capturing data so we can know how we're doing. So this is the real brainchild of Brad Coles and my other colleagues in our department and working with IT. We're creating a web cloud-based app that captures data from real work. So from the dispatching calls right through tools that are used in the field, integrating 3 different database collections that are going to be able to import and export to hospital medical records what's happened to these patients. And now we can get it in one report where we could then feed back to each of the hospitals within each of the hubs. And we're looking at, our goal would be to be able to get 10 hubs with 100 hospitals. We're going to start Duke, North Triangle, Chattanooga, and expand outwardly as our funding gets better. And same process that you've probably seen this before in RACE. It's an iterative process. So the first 6 months is we're developing the database, testing it in North Carolina in the Triangle and in Tennessee in Chattanooga. While that's being implemented, we're building a consortium. We have an external and an internal board of advisors, including most of the PIs for those large clinical trials that are going to be our external board of advisors and the PI for each of the hubs. Implement the database across our state in Tennessee, Virginia, South Carolina as it's funded. And then after a year, becomes iterative. We're optimizing what each hospital and each center is falling short on. And then we're linking on the back end with work that's been done through work you'll hear later through Compass to say, well, what happens when they leave? How do we make sure they don't come back again? And so my next 2 colleagues will be sharing how we prevent that stroke the second time around and how we improve their discharge from hospital recovery and access to the therapy that makes us the whole thing not have to be just a Groundhog Day over and over and over. So, and I figure if we start with Bill Gates, we should end it with Steve Jobs, since I am a Mac person. And I really think more than ever, we're at an unbelievable cross point here, where we're going to take incredibly good technology, pharmaceuticals, and teamwork and translate it now into systems work, which actually gets the patients what they need.
Can you hear me? All right, thank you so much. So I just want to get a quick follow-up on James' talk regarding the prevention side. As we all know, atrial fibrillation is one of the major risk factors for stroke. It affects more than 5 million Americans in this country. It increases the risk of stroke by a factor of 5 times, regardless of your age. Although the burden of stroke caused by atrial fibrillation is pretty high, this is also a preventable cause of stroke. By using the CHAS score, we can actually stratify this patient's risk and see, whether whether these patients should be treated with the oral anticoagulation such as warfarin or NOACs. But now we want to look at the other side of the equation, which is among patients with atrial fibrillations, and once they have a stroke, what kind of medication they have been taking. If we see a high proportion of patients are now taking warfarin or NOACs, this may actually represent an opportunity for improvement. So how are we going to do this? We analyze data from the Galveston Stroke Registry, which is the largest stroke registry in the world. We include almost 100,000 patients with ischemic stroke. All of these patients have some medical history of atrial fibrillation. And then we analyze what kind of medication this patient has been taking before they have a stroke. As we can see on the bar chart, about 30% of patients were not taking any antithrombotic therapy at all. About 1/3 of them are only taking either aspirin or clopidogrel or dual antiplatelet therapy. And only about 20% of patients are taking warfarin, but unfortunately their INR is less than 2, which may actually explain why they have a stroke in the first place. And only a small percent of patients, about 8%, were taking NOACs, and 7% were taking warfarin with an INR of 2 or higher. So, and then we also do the analysis among patients with a CHEST score of 2 or higher, meaning these patients should be on oral anticoagulation, but somehow this still a large portion of patients do not taking this medication. Taking those together, about 85% of patients are either not taking warfarin, or if they are taking warfarin with subtherapeutic range, or not taking NOACs. So, and then we ask the question, why these patients were not taking oral anticoagulation in the first place? So here's the results. As we can see here, about 16% of patients, they do not take oral anticoagulation before they have a stroke because of the risk of bleeding. The other thing I would like to mention that all these patients have a CHEST score of 2 or higher, meaning these guys should be on those medications. And then about 10% of patients, they do not take this medication because of risk of fall. About 2% either because they have allergy or serious side effect. And about 4% of patients, they refuse it. So taking all of them together, only about 1/3 of patients do not taking those medications with a legitimate reason. Or alternatively, at least 2/3 of patients should be treated with medication, but they are not taking those medications. By looking at the incidence of the stroke in the United States, this actually translates to about 60,000 patients could be prevented from having a stroke. So taking oral anticoagulation not only reduces the risk of a stroke, but once the patient has a stroke, they also reduce the risk of more severe stroke. In this figure, we show the distribution of the NICE stroke scale, which is a stroke severity measure among all these patients in different treatment groups. As we can see here on the right, those patients having either warfarin or NOACs, they're less likely to have more severe stroke than those are not only on any antithrombotics or antiplatelet therapy only. And also, because of they are taking those medications, they also have a very low risk of in-hospital deaths as compared with other groups. So in summary, taking oral anticoagulation will prevent patients have a stroke in the first place. And once they have a stroke, they also reduce the risk of more severe stroke and prevent from lifelong disability from stroke or death. So that's a huge opportunities we have here. The other thing I would like to mention that you probably have already noticed that a small set of patients, they are already taking either warfarin with a therapeutic range or NOACs, but unfortunately they still have a stroke. But as of today, there's no good knowledge how do we treat these patients. We call it therapeutic failure for NOACs, which occurs about 1 to 2% among patients taking NOACs, and also up to 5% of patients will actually having intracerebral hemorrhage. But so unfortunately, so far we don't have very good data. How do we treat these patients? One example, for instance, if the patient has taken NOACs, unfortunately have a ischemic stroke, should we give them TPA? Or if their bleeding occurs, how do we stop their bleeding? Can we use a reversal agent? You probably already know that for NOACs, there are only one specific agent for dabigatran reversal agent, but not for others. So it's actually there's not good knowledge how should we treat those patients. So in the past, most of this information actually getting from the small single center case series or case report, but obviously those studies are subject to reporting bias. And because of the small sample size, it's really hard to do risk adjustment. So because of this, we actually working with Heart Association along with several pharmaceutical companies to launch a new registry called ARIMUS. The goal is this is a multi-center cohort study. The goal is to enroll about 10,000 patients taking either NOACs or warfarin before they have a stroke. We want to see what their treatment are, what their anticoagulation measures are, and how does this measure will influence their treatment decision. And also a small subset of these patients, about a quarter of them, will be enrolled in a follow-up study at 3 months and 6 months. We want to look at their patient-centered outcomes and how does it look like in the long run. So far, our target goal is to have the total of 100 and 150 hospital enrolled. Thanks for the hard work from our team members. I see Koala and Abigail sit in the back, and also Laurie. So we already have 60 sites signed up for study. So we are hoping to finish the enrollment in the next 3 to 4 years. And then moving forward, once the patient survives from stroke, we also face the same challenge. How can we put this patient back on either warfarin or NOACs? I remember clearly that when Emily, Adrian, and Barbara and I was developing the protocol for the PROSPER study, we have a conference call with a patient investigator by the name of Eric. He clearly said to me, I don't want to take rat poison. It's so complicated to use. Can you teach me how to get rid of warfarin? And then actually I was shocked by his response. Does he understand what's the benefit of warfarin? As you know, for us as a physician or medical researcher, we definitely know there's tons of evidence supporting use of warfarin, but apparently this information may not be transparent for patients. Let's take an example. So this is the results from the LIFT trial, which is published in Lancet in 1993. The conclusion said, compared with placebo, warfarin substantially reduced the risk of MACE during the mean follow-up of 2.3 years. I guess, for us, it's very easy for us to understand what MACE is. But I have to say, before I went to medical school, I have no clue what is placebo and MACE is. They truly don't understand the concept. To make it even worse, what is hazard ratio and 95% confidence interval? Apparently, our patient has definitely need to take a stat class in order to understand those concepts. So can we do it better to educate patients what the benefit of warfarin? So here in PROSPER study, we actually get the feedback from patients. What they say is that we want to be out of the hospital. We want to be alive and stay with the family. So we translate this concept from a clinical endpoint into a patient-reported outcome measure, which is home time, defined as the number of days patient out of the hospital, not in a nursing home. And then we demonstrate by taking warfarin, patients can gain almost 48 days by taking warfarin compared with those not taking any of the oral anticoagulants. So by translating this method, patients can actually easily understand what the benefit of warfarin are. And actually this study was highlighted as one of the premier funding from the PCORI results. So I'll stop here, and Emily will talk more about the results from the PROSPER study.
Okay. Okay. So. Harder than it looks. All right, so as Ying mentioned, I wanted to talk a little bit more about the study design of PROSPER. I think this is a really unique feature that we hope will be used in future projects and really optimizing patient engagement at multiple phases of the study to make sure that patient priorities are reflected in what we study and in the way that we disseminate results. So for Prosper, as for other projects, we started as a group of investigators with a number of study questions that we thought were really important and knowledge gaps that we thought could be appropriately addressed with this project from a clinical standpoint. And one of the unique features here that I think has really enriched the conduct of the project was that we actually asked patients whether these were clinical outcomes that resonated with them. So we did a brief survey. We're interested in both how patients get information about stroke to address some of the educational gaps that have been mentioned by other speakers today, but also what outcomes were important to them as they recovered for stroke, and wanted to make sure that our study aims reflected those priorities. Did the same thing actually with therapeutic areas. So we know that there are concerns about safety and effectiveness of each of the therapies that are listed here from the patient perspective, and actually revised our study aims to make sure that we were only studying those therapies that patients identified as potentially problematic in terms of their perspective on safety and effectiveness, and also had an open-ended question about issues that were important to them as they recovered from stroke. So that led us to a study framework that we think reflected both the outcomes of interest from the patient perspective as well as the therapeutic areas. Today I'll be focusing on the statin therapeutic area. As Ying mentioned, we did come up with an outcome of interest here that we use as our primary outcome, home time, which is represented by days spent alive and out of a hospital or a skilled nursing facility. We know that mortality and stroke and cardiovascular readmission are obviously important as well, so we built those in as secondary endpoints and are currently in the process of collecting data on patient-reported outcomes, including depression, functional status, quality of life, and fatigue. So really proud of the comprehensive nature of the framework that came out of our early discussions with patients. So in terms of comparative effectiveness of statins, certainly from the researcher perspective, we know that ischemic stroke patients are at high risk for recurrent events, and national guidelines recommend statin use, but efficacy data in support of those guidelines comes primarily from clinical trial populations, which you know often do not look like real-world populations in terms of comorbidities and age. So it's important to make sure that those results apply in clinical practice and that they're generalizable to patients who may not be represented in trials. But from the patient perspective, as I mentioned, we did hear that statins carry concerns regarding benefits, long-term benefits and potential risks. Home time, again, was identified as a high priority outcome. It hasn't been investigated commonly in clinical trials, so we wanted to make sure that we were providing some meaningful evidence with regard to that outcome. And really that knowledge was disseminated in a way that could better support shared decision making and make sure that patients feel empowered to use that knowledge in making decisions about post-stroke therapies. So as Ying mentioned, in Prosper, we wanted to use both the detailed inpatient data from Get With The Guidelines Stroke as well as the longitudinal data from CMS claims. The inpatient data from stroke has Get With The Guidelines Stroke has detailed covariate information, which, as we know, is really important for covariate adjustment in observational analyses. And then through the claims data, we were able to investigate vital status and readmission, as well as to calculate days spent alive and outside of the hospital for our home time outcome. So what did we find? About 71% of patients in our analytic population received statins at discharge. Over 2 years after stroke discharge, statin users did have a 9% lower risk of major adverse cardiovascular events, about a 16% lower risk of mortality, and a 7% lower risk of readmission, comparable rates of ischemic stroke, hemorrhagic stroke, and CV readmission relative to statin users, and these are all adjusted estimates. And as Ying mentioned, we were interested in this potential home time benefit as well. In unadjusted analyses, we saw 71 additional days at home in the 2-year period following discharge in statin users, and then following adjustment for relevant clinical characteristics, about 28 additional home time days. So in addition to those two conclusions, we did see that this benefit was preserved across clinically relevant subgroups, which, as I mentioned, was really important for that generalizability aim of the project. We didn't find significant differences in MACE or home time for the high intensity statin users versus low to moderate intensity statin users. And then finally, we wanted to make sure that these results not only made their way into the scientific literature, but were also published in ways that patients could understand and potentially use in the decision-making process. So along with our stroke survivors, we designed a website that presented both the results overall and also by clinically relevant subgroups, as well as some supporting information about what a statin is, why it's recommended after stroke, what the risks and side effects are, and some additional resources for more information. One of the parts of this project that we're most proud about is that the patients, as I mentioned, haven't been involved just in the study design and dissemination, but also in the actual writing. They're published authors. They were co-authors both in our statin and warfarin analyses, but also in a patient perspective piece that was published in Circulation, Cardiovascular Quality and Outcomes. And just wanted to provide this quote as a representation of their experience and involvement with the project. And it reads, "As patients, we must accept the responsibility of being advocates for our own healthcare, and we cannot do so if we are not empowered by a fundamental understanding of medical research. As co-investigators for PROSPER, we were working alongside doctors and scientists to answer key questions about quality of life, depression, and fatigue that have often been neglected in clinical trials." So we're hopeful that we can apply the lessons that we've learned in working with patients through PROSPER to future projects and really make sure that patients are engaged in a way that's fulfilling to them and improves the study design and the analyses that we do. Maybe I'll just hold this instead. So thank you. This is actually a good timing to say thank you. Thank you for being here with us to celebrate the close of Stroke Month today, May 31st. We're really excited about the advances in stroke, and I think, Carmen, your slide about where we've been for the last 20 years, and yet the work that has really been accelerated, particularly with the teams here out of the DCRI, is exciting. Looking forward. And what I want to talk with you about is the opportunity we have now, particularly for those people going home. If we're really seeing the advances that we're seeing in science in practice, we should ultimately see more people go home and more people go home with the support that they need. This here is a representation. When you think about almost 1 million stroke admissions every year, we know about half of those stroke admissions, those patients and their families go directly home. So you imagine you have a stroke and about 4 days later you're going home. Now in this country we see that as a really positive outcome, right? And most of our studies look at it that way. You have a stroke, you go home, or you have an event, you go home, and discharge home is a positive thing. And I would agree, it is a positive outcome, but look at the differences. We're seeing that people who are younger, more people that are younger are going home than people that are older. And this is independent of how severe their stroke is. So are we really leveraging the resources we have appropriately? We don't yet know. And this is where we think, well, what about the needs of our young strokes? We do so much of our analyses linking our data to CMS claims that we really don't know this population as well, what they need. Are they returning home? Are they able to be parents, young grandparents? Are they able to return to work? And this is a really tremendous gap here that we have essentially twice as many people in that or higher proportion going home. So great, they're going home, but from a patient perspective, is this what it looks like? I just had a stroke, you're sending me on the bus out of here, right? I'm not swallowing as well. I may be unable to remember things as well. Can I do the things I used to? Can I take care of my kids? And so we're sending them home, and the opportunity here around medications, around adherence, even minor deficits, is do we have a system that best supports them? And this is where I think some of the work is going to accelerate really quickly in being able to shift practice and shift systems of care. And that's what I want to focus on. 5 examples, really clear examples of where we're going in the next 5 years. The work actually started here. We were asked from AHRQ, do we have established evidence for transitional care for stroke? And we published in 2012, like every other study, ultimately the last line, evidence about benefits of other interventions and harms from transitional care services is insufficient. So this was in 2012. Unfortunately, we're not that much further 4 years later around interventions that best promote a successful transition home and back into the community, but we're getting there.
What happened after this study, landmark, I think, out of our work here, out of the DCRI, was the Centers for Disease Control used the findings from these studies to leverage the message that we needed more funding to be able to study this. They then, so the CDC had commissioned that systematic review. They went back then, under the Paul Coverdell National Acute Stroke Registry funding out of the CDC, they were able to fund 3 states to pilot interventions for 3 years around transitional care for stroke. Massachusetts was funded. They tested a hospital to skilled nursing facility relationship. Michigan was funded, and they tested the 30-day outcome measures. It's a 30-day follow-up form and get with the guidelines, and were we able to actually measure outcomes at 30 days. And Ohio was funded, and we tested follow-up from primary care and neurology. Out of the group of Ohio, so we worked with the team in Ohio, and we essentially used the heart failure model for performance metrics to be able to schedule appointments for patients prior to discharge. So you'd think patients have appointments scheduled prior to discharge. Well, they didn't. Actually, most of the hospitals don't automatically do that for all patients. It's kind of an assumption that that happens. And so we established performance measures for stroke. We were able to test them in the infrastructure of building on top of the Get With the Guidelines data registry. And we supported through a quality improvement collaborative having hospitals slowly and iteratively test different things to be able to schedule patients. Now you think that that sounds kind of easy, right? We're scheduling an appointment with a primary care physician or neurologist after discharge. Not quite so simple. The good news is, from the testing that we had done, is that these performance measures have now become a national standard. And in the funding that came out from CDC for 9 states in 2015, these performance measures are now established metrics that all states now have to report on. So we're hoping that these will now be reviewed by the National Quality Forum and will be established performance measures for stroke as they had been for heart failure. A really significant advance that essentially came from the work that we did from a systematic review that said we really need to be doing more in supporting these patients going home. The third piece then, so that was second out of CDC. The third, as Carmen had already alluded to, is the COMPASS trial, recognizing that most of the interventions that we were building our work of were tested in countries other than the United States. PCORI funded the first pragmatic trial of transitional care, and it's here in North Carolina. So it's taking the best components and the strongest components out of interventions for other patient populations, primarily heart failure and COPD, and being able to combine those with what we know out of some of our European models for what's called early supported discharge, and being able to integrate those into a model that supports patients going home. The COMPASS trial, Comprehensive Post-Acute Stroke Services, is being coordinated out of Wake Forest Baptist by Pamela Duncan, who many of you know, as she used to be at Duke. Many partners, and I couldn't fit all of the logos, but it goes on and on. Just imagine, to do a pragmatic trial with 50 sites in one state takes a lot of people involved. But it's essentially, as I mentioned, leveraging the strongest evidence-based components and seeing if we can actually do this here in North Carolina. Duke is a site on this trial, and several of us are co-investigators in being able to make this happen. This, as well as the Centers for Disease Control measures, 5-year study. So ask me how things are going in about 2018, and we'll have some great evidence. But even just being able to pull this together has been an extraordinary opportunity to learn how to be able to iterate and develop within health systems that are already facing so many other challenges in meeting external needs. And this is recruitment so far. We just finished training our first randomized sites, and we'll continue through next year. The fourth major advance is thinking about, well, what happens for systems that don't have the services like we do here in the United States. We worked with our partners in China to think about, well, they don't have all of the trained expertise and professionals that we do here and in other developed nations to launch the RECOVER trial, a randomized controlled trial of rehab through caregivers and nurses. Ultimately, what we did was we focused on the nurses in these rural county hospitals, trained them from teams out of our major cities where we had those expertise. The nurses trained families prior to discharge. They have a slightly longer length of stay of a week, so we had more opportunities to engage with the patients and families. And then the families were then carrying that care plan forward as they went home. We just finished recruitment. We'll have our 6-month follow-up data by October. This is a really exciting opportunity to think about how can we then shift care models to areas where resources are different than our own. And What has been really fantastic about this trial is that we've now, this is also being tested in India, and the Robert Wood Johnson came to us and said, well, shouldn't we also be testing this here? Because there are many places in this country where we don't have the resources that we do even around Duke. So a great opportunity here that is now launched into the fifth final story I wanted to share with you. This last January, we launched the Global Alliance on Disability and Healthcare Innovation, being able to think about how do we now share what we're learning across countries, being able to standardize data collection so we could do more of this work globally. Funded heavily by Duke right now. We have proposals being reviewed right now for Tanzania, Uganda, Argentina, and Brazil, ultimately to be able to share some of the work that we know is already working in Sweden, in the Netherlands, in Norway, in China, and here in the US with some of our developing nations. Really exciting work with a really large team right now, hoping that we're going to at least shift care and practice around the world. A lot of exciting changes, and I think with all of our work going forward, here we sit kind of on the verge of what do we do with what we're learning, how do we get that into practice? New quality measures, new care models, new opportunities to support patients, and ultimately to improve capacity for better care and better outcomes. Thanks.
Great. So I'll invite our panel members to come to the front. We have about 10 minutes for questions, and I know that many of you in the audience have been involved with a number of these projects, so I'm hoping we can have an interactive discussion as a group.
Thanks.
Okay. Happy to take any questions.
I actually have a question.
Okay.
So one of the dilemmas, and I was curious how you're going to find this, in the patients that have AFib that are not on treatment, and we're looking at educating them to be advocates for themselves. When I see patients with AFib coming in with stroke, I ask them, did you know you had AFib? Because you're not on a blood thinner. And they'll look at me with this deer in the headlights and say, I've never heard of the word AFib. So how do we ascertain what the patient's knowledge of their disease is? Because if we're going to send them educational material, if you see all those commercials with the guys playing golf and having a great time on Rivaroxaban, I think the patients would advocate, but they don't even know they have it. So how do we do at making sure they know they have it?
So that's a really great question and was a really important part of the formative research that was done. So we know from the claims data that they have been diagnosed at least, I think it's twice in the last year, 2 years, with AFib. But, I think we were all on board, and we have a fantastic patient investigator as part of the team too, that we didn't want to send anything shocking through the mail. And so, essentially what we've done is we acknowledge that that's an issue. We don't want it to sort of slow down our progress, but we've tried to be very careful in the language that we use. And we do encourage them to go in, to make an appointment with their physician and to talk to their physician about their diagnosis and appropriate treatment for the good of their health, particularly reducing stroke. So, it is something that we've decided to sort of tackle with the language, but we have encouraged them to talk to their provider rather than us to try and educate, that part in this single mild intervention.
So just to follow up to that, again, I come from a personal family situation with stroke, and thinking of my 80-plus-year-old father getting something in the mail that isn't from his doctor, that tells him to go check with his doctor. It would seem like something that's on a commercial on TV to ask your doctor about. And so it's a trusted source versus an untrusted source. And so that would be something where with your patient advocate on board, how do you, especially the older you get, the more lacking in trust people tend to be with stuff coming into their house that they didn't ask for. You know what I mean? So that's kind of a real obstacle or potential burden with the older population.
I think that's a great point. again, this is a fantastic opportunity to try and, conduct a national intervention to reduce stroke, but we also are keeping in mind that this is a sort of proof of concept study simultaneously. So we're not looking to stratify the intervention that we do. We actually want to, send out a single mailing and see what the reaction is. Interestingly, we're intervening both with providers and with patients. Providers, for example, have said, okay, FDA is a partner, let's see something from FDA. That will make us open it, that will make us engage. It's quite different when we talk to patients. Then what they sort of say, well, we want to see it from our health plans because that sort of makes sense about why you might have this information. But could you please include the name of our provider? And that's been important. And by name, one of the requests too, unfortunately with randomizing 30,000 patients, it's not going to be possible, and could you sign it in ink? So there are all these sorts of things that are sort of really important to think about as you do this, but I think your reaction is exactly right, and I think that as the data comes in, what's wonderful about using the Sentinel platform is that we have it's a huge, it's particularly for a stroke study, it's a huge study. So what we're hoping is that we may learn, where the message that we do send out resonates, where it doesn't, and then, if this platform is useful for future research, we can study different things in the future.
Yeah, the other thing I want to mention that for those who are having AFib but not on any of the oral anticoagulation, we could not put the blame on all the blame on patients. Sometimes it actually happen on the provider side. There's still some misperception that aspirin is effective, and it doesn't have a high risk of bleeding. That's quite common among the providers. So I think a better education, not only for the patients, but also for the providers, might provide one of the options.
Yeah, so just actually following up on that, you mentioned 48% of CHEDS FASC over 2 were not getting any treatment, right? So there are always these elements in decision-making processes between patients and caregivers which are not captured in registries and are a little bit hard to get into. So have you thought of any other ways to capture this?
So in what we send out to the providers, there is actually a response mailer too, for a number of reasons. First, we never wanted to be in a situation where we're trying to tell providers what to do. And exactly as you say, they may have had a fantastic conversation with the patient that we're reaching out to them about and been really thoughtful and actually decided, despite the guidelines for this particular patient, we're going to do this. And we certainly didn't want to be sort of ramming this instruction down anyone's throat. We wanted to give them a forum to sort of respond because that's important and respectful, but it's also a really good opportunity, we hope, for them to be able to share back information with us. And I think, some of the other presenters shared that there is this, these different populations of folks, making these decisions, and we hope to gather more information about that. So on the provider side, we do have that response mailer that either they may sort of be able to respond to immediately based on what they know about previous interactions with the patient or subsequent to future interactions. And so we hope that to be valuable.
And I would also just add that I think one piece of this is really just characterizing what the status quo is with regard to shared decision-making and patient education. And we have a sub-study as part of the National AFib Registry where we're asking patients, did your provider mention this therapeutic option to you? Do you understand what warfarin is? Were you part of your decision-making process? And we're seeing some pretty striking findings. So I think just making sure that data makes its way into the literature and that providers become aware of the fact that this is a problem and potentially funding projects in the future to address those gaps and to empower patients to be part of that process. Jeff, did you have a question?
Sure. Yeah, sort of along those lines of understanding what kind of drives this apparent poor quality, and I'm mostly thinking about the anticoagulation, but it could also be applied to secondary prevention, et cetera. I mean, do we have an understanding, sort of like the provider level variability? Are there systems that do really well that maybe anticoagulate like 70% of their patients? I think as a provider, it'd be more compelling to me if I saw there was this wide variation. Maybe I was at the lower end, then every provider, 45 to 55% of their patients are not anticoagulated. Then I start to think there's something outside of my control.
So I think all of us are interested in provider variation, and we build that usually as the second level of analysis on top of our patient analysis. I think an important point, though, is when we looked at follow-up among our stroke patients, they often don't know who to go see, right? So it ends up being a really big question of who ultimately should manage their care. And we don't have enough neurologists, and we really have a hard time still trying to get them in to see somebody. And so if it's somebody who's already had a stroke, they're not seeing a neurologist in most places of the country in the first week, not in the second week, maybe in the first month. About half see a neurologist within a month of their stroke. And so then does that turn to the primary care physician? And that ultimately changes, right, who you end up working with and how you share that information. So while you may see systems that are better, really trying to understand what happens locally ends up being key. So I think your question on variation is important, but really trying to understand what it means in kind of a local system ends up also being a big driver, because where there aren't neurologists, we really need to be working with primary care and who should be following up with these patients to give them that information. Have you looked at provider variation in this yet?
Yeah, I think that's a great question. Although we didn't have a chance to look at the provider level variation, but we do have a chance to compare US and Chinese data and see what's the prescription of oral anticoagulation among patients with atrial fibrillation having ischemic stroke. So in the United States, it's about 70%. Meaning that these patients have a medical history of AFib and having an ischemic stroke, so these patients should be on oral anticoagulation, but only about 70%. But also there might be some cultural difference in other countries. For instance, in China, only about 20 to 30% that actually highlight, there's definitely more work that need to be done in this field to improve the adherence to the medication and improve the appropriate treatment among those patients.
Yeah, I think one of the things that we see very commonly is the misinterpretation of perceived risk by the providers. So when you look, if you ask providers, what is the anticipated bleed rate on somebody on warfarin, the numbers are unbelievably scattered. And if you actually look at the data, it's only about 1%, well, 0.1%. If you look at the perceived risk to the patients, the fact that it's rat poison is very scary. And I mean, again, the other one that has to do with there's not the same commitment by providers to be managing the Coumadin if you're going to go on warfarin, because that is a very labor-intensive task. And then with the NOACs, the perceived risk that they see out of these agents is completely disproportionate to the actual factual knowledge. I mean, we know that apixaban, for example, has the same risk as aspirin of causing a bleed. And so if you said to the providers, there is a drug you can use that's an anticoagulant that is no more dangerous than aspirin in terms of major bleeding, I think it would probably change. So I think the education that we have to do is in the perceived risk of these treatments. They're all on aspirin, so it's not that they're not treating their patients. And that's what we run into on the acute side with the perceived risk by emergency physicians of using thrombolytic therapy. It's completely blown out of proportion to what the actual risks are, and then we can't engage patients if we don't engage the person offering the treatment first. So I think this is wonderful because it gets the patients in the conversation, but we have to go back to the providers and, again, re-educate. And that's where this issue of translating from clinical trials to actual practice is where the cliff falls off, because it looks great in a trial, and then you ask people to change practice and have very misconceptions of what it is they're supposed to be translating.
So I think that's it for us for time. Maybe we'll plan another session in 3 years. We'll have all these problems figured out, and we'll report the results of some of these projects. Thank you.